Hello, I'm Dr. Eric Pfeiffer, Director of the Suncoast Gerontology Center at the University of South Florida in Tampa. Welcome to the second part of our film series on understanding and coping with dementia. In the first film, we focused on issues related to recognition and diagnosis of dementing disorders. We also focused on the kind of an impact that the disease has on patients and on family members. In our second film, we will focus on issues of management of the dementing patient. We will focus on the role of the physician, both the general practitioner and the specialist consultant. We will also focus on the role of other members of the health team. And very significantly, we will once again focus also on the role of the caregiver, the lifeline to the dementing patient.
It's like caring for an infant or an animal. She can't express where she hurts, if she hurts, or what's bothering her or troubling her. At first, she would come to me and say, there's something that I need to do, but I don't know what it is. Now, she's really coming apart at the seams now.
And you?
Well, and me, I've had bleeding ulcers twice, shingles, heart arrhythmia, and I'm taking tranquilizers. Does that tell you?
Tell me what you're trying to tell me with that exactly.
Well, I see things, or I'm with him all the time.
Yes.
Maybe I look for things that I shouldn't, you know.
You're sort of saying you don't know the half of it by a long
That's what I'm
shot.
trying to tell you. You don't know that.
Yeah. What in particular about his current level of functioning is getting to you?
It is bringing up the idea that the guests in the house, are we going to take them out for dinner, or where are they going to sleep tonight? And there's always somebody in the house, and
He has illusions of other people
being there, yes,
and that really gets to you.
Mhm.
Tell me how you've been getting along.
Pretty good.
Pretty good.
Yeah.
What do you do every day?
What
How
I
do you
do
spend
every
your day?
Well, we go to, gives up on the other way,
Mm-hmm.
but in a way, I don't know the name of my,
You go out with friends sometimes? Uh-huh.
oh yes.
Okay. Tell me, do you have any problem with your memory now?
A little,
A little.
yes.
What way does it show up when you have a problem with it?
I don't know how I could say that.
Does it cause any problem to you or to your husband to have the problem with your memory?
Doesn't make any difference.
Doesn't make any.
She gets up in the morning, she's fairly good, within about an hour or so,
Uh-huh.
she gets very weak.
Yes.
She has to lie down again. There seems to be any coordination.
Tell me what that is doing to you and what effect it's having
Well,
on you.
it's stressful because it's bothersome to me that I don't understand it. And of course, as I say, we're just the two of us,
Yes.
and it's difficult at times to comprehend.
I was feeling that in the last couple of times we talked that maybe you were getting stressed to the point where maybe you needed some additional help and assistance in coping
Yes, it
with the
would be
situation.
nice.
As I was telling you the other day also, that I would like to invite you to come in and see me just for your own emotional needs, because I think you two are now personally about as stressed as you want to be.
But, yeah, sometimes I do feel that way.
Uh-huh.
But the thing is, we've always been close, the two of us.
Oh, yes,
We've been married 46 years, we've went through a lot.
yes.
We've always been together,
You are very close.
so we're close. So that's the only thing that I'm thinking of, is whether she will accept any outside help.
Well, I think the point would be that you will need that help in order to be able to be of help to her. Once the family has absorbed the initial impact of the disease, there is then the issue of how to provide continuing medical care for the patient. Well,
what kind of ongoing medical care is needed. First, regular medical checkups about every 6 months. Second, ready availability of the doctor to treat any intercurrent illness that may arise. And this may include willingness on the part of the physician to make home visits. Patients with chronic dementia are somewhat more fragile and more sensitive to disease-producing situations. And intercurrent illnesses, as well as concurrent illnesses, must be treated promptly and completely. The simplest, the least invasive diagnostic procedures in the least disruptive setting need to be selected. Along these lines, we must be especially sensitive to the potentially very disruptive effect that even short-term hospitalization for just a few tests has on the patient. Dr. Ackerman, a family practitioner, is involved in providing ongoing medical care to patients with dementing disorder. Here he is shown as he meets and examines Helen Bodoff, the patient, and as he discusses her situation with her husband, Manny Bodoff.
Good morning.
Hi.
How are you?
You just did.
I'll let you sit there.
How to do?
How are you, sir?
Good.
Welcome to Florida.
Oh, yeah.
Oh, we've been there for a long time.
How have you felt since you've been here?
Well, what do you say?
It must be about at least 20 or 30.
What? Well, he's asking, he wants to know how you're feeling here.
I'm
feeling
feeling as far as him.
Yeah.
Physically and
Yeah, physically.
Physically, yeah. My physically is very well,
good.
very well.
First of all, it is impossible to rely on the patient to exercise individual responsibility in managing their care. I mean, it's necessary to have the family or some support system to help in assuring good continuing care, as they can still have infectious disease, they can still have malignant disease, they can still have the cardiovascular and respiratory problems that any of the rest. And it's incumbent upon us to watch for these ancillary problems, even though from the standpoint of the patient and particularly the family, the mental symptoms are primary and cause the major part of difficulty in managing their care. Oh, you had pretty eyes. Good. Now let's look at the other one.
Do I blink the one or the other?
You do just fine. That's good. That's fine. That's, you know, it's interesting. Inside your eyes is the only place in your whole body that we can actually see a blood vessel, and we can see the little arteries in the back of your eye. And we do have to rely more on physical examination, and along with physical examination, the ancillary features of X-ray and all. And yet one of the biggest mistakes that doctors in general are likely to make is to go too far in pursuing these diagnostic examinations. I feel strongly that this patient needs to have the minimum of distressing examination, distressing procedures. You have an excellent blood pressure. Have you ever had any blood pressure problems?
You know, with all these things, little ones, you know, and push it on and go. That's how they.
So blood pressure is good?
Yeah.
It's excellent right now.
Excellent.
Now, if you'll let me just see how your heart's beating.
You could do
No, it's okay.
take it.
I'll do that for you.
This patient put in the hospital in the strange and somewhat awesome aspect of hospitalization, even though the patient is receiving excellent support and excellent care, the patient frequently will have a
very strong negative reaction and even a further breakdown in their mental activity that they simply won't be able to get over it.
She was there 3 days and 2 nights, and they were the most harrowing 3 days and 2 nights that either one of us have ever spent in our lives, because she went just absolutely, well, she just changed like that. I mean, she was just shaking and trembling, and blood pressure went up to 220 over 110, because she was in a strange place, with strange people, doing strange things to her.
From what I understood,
Nobody got any sleep.
so that they were relatively routine kinds of things that were being
They
done.
did very little to her. All the studies that they did, for the most part, were done in the lab, and they were blood samples, which they took once or twice. That's all.
You're also the daughter of a patient with this kind of disorder. What do you think makes hospitalization, which in many ways was a very undramatic kind of thing, what makes it such a difficult and disruptive kind of experience, do you think?
Because the patient's fears, and because of the patient not understanding. Also, the staff do not understand. It bothered me to see the lack of knowledge at a hospital and the treatment that's given to an Alzheimer's patient.
Tell me what you saw and what you were reacting to.
Okay, in the emergency room, there was no explanation of any treatments or anything. They were just done. And the fear that was felt by the patient was very strong. I can't say this was just from my mother's standpoint. This was just from an observation during the entire time. From the emergency room itself, she was sent to a holding area because there were no actual beds. So there were 2 nurses for 3 patients, and I was not allowed in there.
Depressive symptoms may occur in dementia. Early on in the disease, antidepressant drugs may be quite helpful in relieving this symptom. They may also be helpful in serving as a therapeutic trial to distinguish between the pseudodementia of depression and true dementia. In advanced stages of dementia, the antidepressant drugs must be used with extreme caution, since such patients are very prone to develop side effects, especially increased confusion. Daytime restlessness and nighttime agitation, also paranoid delusions, especially when they frighten the patient or lead to aggressive behavior, respond very well to low doses of the major tranquilizers. A number of anti-dementia drugs are also available. These may be able to reduce the symptoms associated with dementia in some patients, especially early in the disease. This is also an area of intense research investigation, and we are hopeful that new drugs will be available soon.
Up in the management of patients with Alzheimer's, they're particularly sensitive to medications, especially medications that affect the central nervous system. And you really need to be aware of this when you're trying to treat problems that arise in these patients. They are particularly liable to decompensate medically as well as mentally if they are stressed by some sort of an acute medical problem. So you really try to prevent the development of a severe medical illness. The real purpose of your medical care is to try to intervene at early stages of such things as infections, heart disease, other problems, to prevent them from becoming a crisis. Crisis will tend to not only make the underlying disease worse, but it will also aggravate the Alzheimer's disease. The families also need a lot of support, and I think the physician is an important person in that support mechanism.
Another factor that enters into it, I think, is the opportunity to develop a team care for a patient. Now, many times I feel like I don't need a nurse in my office. I'd rather have a social worker working with me. Many of these patients do not have good support facilities, and to be able to involve the social service people, to be able to involve the actual helping people, to get frequently the most necessary thing in taking care of this kind of patient is to get just daily help, to get somebody in to straighten up the house, to see that they get food through Meals on Wheels or something similar. Oftentimes, the support, even such things as physiotherapy, occupational therapy, to try to, as this process proceeds, it's necessary to frequently reteach the patient the normal activities of daily living. And this cannot be done by me as a physician. It has to involve a team. It has to involve other people, and this can much more effectively be done where you can take advantage of the home situation. The patient and the family are going to look on the physician as the primary contact. The other people, no matter who I as a doctor may involve in the patient's care, the patient still looks on me, and the patient will feel completely lost if I don't maintain that contact with them. That's very good. I'm proud of you. I think that's all we'll do right now. You're a good patient.
My name is Lillian Middleton. I'm a clinical social worker. I work at the Suncoast Gerontology Center at the University of South Florida. At that center, I'm involved in a number of aspects of patient care, but in particular, I focus on working with Alzheimer's patients and their families in sort of a counseling and supportive role. That involves some individual work with the families, going to visit them in their home, as well as working with the families in a group setting. I also see the impact of other factors in the home that influence the patient's state of well-being or state of lack of well-being, for that matter. This disease becomes all-consuming for the caregiver, and they need other services at varying times to assist in the care of the patient at home. This kind of assistance might vary from things like getting a homemaker in to assist with some of the household chores, to getting them legal services because of planning that has to be done in that area, things like power of attorney or guardianship, helping them do some financial planning, helping them obtain financial benefits, helping them find services such as daycare in the community that might be appropriate for the patient for a given period of time, home health care if nurses need to come in, that type of thing.
In Alzheimer's disease and in some other dementing disorders, we really still are very limited in what we can do for the patient directly. But there is a great deal that we can do for the patient indirectly by providing whatever care is needed to the caregiver, usually the spouse. In order for the person to be able to do their job, they must have emotional support, detailed information about the illness, information about resources available in the community, and ready access to medical care and medical advice whenever it is needed. There is no substitute, however well-trained and well-motivated, for an informed and dedicated spouse in maintaining maximum functioning ability in the patient's own home for as long as possible.
It's just really devastating what he does now, and so I have to take and keep tools away from him. His workshop over there, where he had so many tools and he built so many things, and I never had a repairman in the house. Now I have to keep it all locked up. I keep my office door locked at all times. We've had to put locks all over the house. What we do is have a sign on the door that says no, and have it in a bright color so he knows he is not to enter it. And then on Jackie's door we have a no also. And then to go on a little bit farther, when it says Lawrence with an arrow, well, he knows that's where he's supposed to go to the bathroom. But we've had to do a lot of things. Because he has a hard time, after living in this home for 10 years, he has a hard time finding his way around it. He isn't real clean in the bathroom. And so we've had to take and put paper on the floor. Sometimes here, when he urinates, he'll just go right alongside the toilet and not into the toilet. So we've had to do that in order to keep the bathroom clean. Then I can change the papers every day. Then another thing that I realized that helping him with baths was a problem, because when you have shower doors, you've only got half of the shower to work with. And I searched and found that a lot of places have this type or similar types. And I found a shower door would come apart like that. It opens up the thing completely, so I have the full thing in order to give him a bath. This, of course, is his room here. And we had to make these changes because all night long he was up and down, the lights on, and it just made it impossible for me to get rest. And when I'm busy in the daytime with him and business too, I've just got to have rest. But for example, he would open and shut the drawers, and he's up at all hours of the night with lights on. So I've made him this bedroom here and put a new bedroom on for myself out here. And we have a clothes closet here, but the clothes closet, you'll see, is empty, other than the fact that I have just a change of clothes for him to put on. His dresser drawers are empty too, because if he had shorts there, he might have several pairs of shorts on. And he might have about 2 or 3 pairs of socks on. He might have 5 socks on one foot. But you had to do things like that in order to keep ahead of him and to keep ahead of his clothes. But we just keep a few little things. Oh my gracious, this is another one of his tricks here. Now I found a pair of shoes in the drawer here. But I tie a knot on the outside of the shoe at both ends so that he can't get a shoelace out. You have to leave plenty of room so that when you gets his foot in there, he's got room. But then when you lace it up, why, it does come on up there and give him room there to get his foot in. But other than that, why, you're just looking for shoelaces all the time. Another modification that we've had to make is with our thermostat for the home. Lawrence kept fooling with it and fooling with it all the time till we'd have air conditioning on, the windows wide open, we'd have heat on and the air conditioning on. So I left this one on the wall and had them put a new one across the way here. And now he can play with this all he wants to, and I don't have to worry about it. I do once in a while say, Lawrence, the temperature is all right, why don't you leave it set the way it is so that he'll feel that it still is the true one. I try to give him as much freedom and independence as possible because he likes that. And he's always been a very independent man, so I want to keep him that way as much as possible. The daycare center, that's about the only thing Lawrence likes anymore, is going to the daycare center. They come with the bus and pick him up every morning about 8:30 or so, and he is up there all day long until about 2:30 to 3 o'clock in the afternoon. And it's a wonderful thing for me to have him gone that many hours. It's a wonderful thing for anyone, really, because it gives you a little break, because so many of them say that there's just too much togetherness. If they could just have a little few hours to themselves, it would be so helpful so they could go out and do what they want to do. He enjoys it. They get a good nourishing meal at noontime, but they do a lot of little handcraft and a lot of little things like that. This is one thing that he made up there, and it's made out of a milk carton. But it was made for Easter. It's an Easter bunny, and they made things at Christmas. But it's just hurt and almost incredible to think a man like him, being an engineer.
I was able to choose one that I had gone to already, and I asked if he would take a new patient and an Alzheimer's patient, and he said yes, and follow through in the nursing home. But you need to go first and talk to the doctor, I think, any doctor. Talk to him, and if he isn't willing to listen to you and talk to you for a few minutes, then how is he going to communicate with an Alzheimer's patient who has very limited communication? Communication is a very important factor. The general practitioner should be knowledgeable enough if there's an Alzheimer's association in the area so that he can give them telephone numbers to call for that. And he should spend enough time with the family and give them social service names and things like that. He should also know what's available in the area from the standpoint of in-home nursing care. And my mother now is 75. I am a registered nurse, and I worked with the general practitioner, and the main thing is keeping their activities of daily living as simple as possible. A lot of people in the home feel that a bath every day should be given. These older people are not that active. 2 times a week and good skincare in between is better for them than drying out their skin with daily baths. It's really important to watch and make sure that they do go to the bathroom, because they don't always realize it. You need to keep them on a regular schedule. You need to watch their water intake. One of the most important things, I think, in the elderly is supervising their nutrition, because a lot of times they don't cook it all for themselves. And unless you really get into the refrigerator or into the cupboards, you really don't know what they're eating. Even when you take the food in, a lot of times they don't eat it, they put it in the garbage. So this is something you've got to watch. They don't always eat like they should. As far as handling their own finances, you don't realize things like they can't open a milk carton, they can't open a bottle. A can is an impossibility for them. So when I had my mother in an apartment, which I did for quite a while, I would always open all the cans and put everything in bottles with loose lids that she could open and close. And the only problem then I had was if she would close the lid herself too tightly sometimes. But got to think in terms of their security from the standpoint of would they open the door to a stranger, or would they go out and wonder? You have to think in terms of how they handle a stove too. I used a lot of red tape. I used red tape and I put it on the high controls. And I taped out broil, I taped out high and medium high. And she could remember that she was to stay away from the red tape. But then I discovered that she didn't know which end of the telephone to put to her ear. So I taped the part that went to the mouth. For her security and for my well-being too, I used the Vial of Life, which is set up by Hillsborough County. Inside is a sheet with all the information from their social security number to the doctors to what hospital. Everything is inside there. The idea is to hook this to the refrigerator. There's a drawing in there to show you how to hook it to the refrigerator tray. And you leave it in the refrigerator, and the paramedics and the fire department and everybody know to look for this, and it gives them all the information then that they would need, the diagnosis and everything. It would save a lot of time, because sometimes these Alzheimer patients don't even know their names, and you cannot rely on them to give you any information. Also, I took her medical cards and I put them in an envelope and I taped them very high on a cupboard. I think it's important to keep the cards somewhere in the house where they can't get to them, the patients can't get to them, but that you have access to them and anybody else does.
Ongoing medical care of the patient may require individual counseling or psychotherapy, either for the patient or for the caregiver. Issues which crop up in interviews with family members cover a whole waterfront of problems.
It was very much of a problem. We had a lot of mirrors. So I took all the mirrors down that could be taken down and turned them backwards to the wall, hung towels over the ones in our bathroom. We had.
Tell me again exactly what his reaction was to the mirror.
He acted like it were some strange man in the house that he did not know, and he wanted him to go away. And he felt threatened by this man. If it had been some man that had entered our bedroom at night, I used to think, could I depend on his strength? I found out I could. He broke our big vanity mirror, like over my vanity, which is like this, you know, the kind you have. He took a pop at it, and he's very strong, and so that's how strong he felt about it. He wanted to get rid of it, and it was somebody that was threatening either me, a stranger. Very much of a problem. We had a lot of mirrors. So I took all the mirrors down that could be taken down and turned them backwards to the wall, hung towels over the ones in our bathroom. We had.
Tell me again exactly what his reaction was to the mirror.
He acted like it were some strange man in the house that he did not know, and he wanted him to go away. And he felt threatened by this man. If it had been some man that had entered our bedroom at night, I used to think, could I depend on his strength? I found out I could. He broke our big vanity mirror, like over my vanity, which is like this, you know, the kind you have. He took a pop at it, And he's very strong, and so that's how strong he felt about it. He wanted to get rid of it, and it was somebody that was threatening either me, a stranger in the house, or him. I think I tried to step aside and evaluate myself, and I might recommend that. It's hard to do.
What did you do?
Well, I just tried to watch myself, what I was doing around Harold, and I've always believed in conversation at the table. But I wasn't doing that, even though I'd advocated it. I'd get a book, and Harold would be sitting there. I would never have done that unless we were both reading, sometimes something interesting. But he was sitting there, and I was reading. And I was simply ignoring him.
Help me a little bit.
Yeah.
Put him in the Jeep.
Yeah.
Right here. Where are you going with him? I don't think I want him in the bushes, Harold. Let's get him out to the street, okay?
Harold's really been a remarkable patient. He's been very strong. I do realize that this is very hard on the family. And you have to work through the family to get to the patient, Dr. Pfeiffer, because there's no clear treatment except the coping. And so that way you're going to have to work through me. And so a lot is centered on me, and Harold's not saying anything. I wish he could tell you what it felt like. How could you ever find out what's going on? There's no absolutes in him. He's not absolutely disabled.
Let me harmonica, Popo, please.
No, this is mine.
But you are going to let me play it.
Well, yes, I know it.
And I brought the children up, hopefully, to be very independent. They also got a certain amount of emotional independence.
Mm-hmm.
And along with that, I still kept a very strong sense of family. And so I didn't look for the fact when I was creating all this independence that I might want to call them home a little bit for a little bit of support. And it kind of made me feel guilty, I guess, and not knowing how to handle it. Sometimes defensive, and sometimes very judgmental, I guess.
You had raised them for one kind of expectation, and along came another one.
Yes, and it's sometimes when I felt critical, I think it was also hurt for their father. How can I put that?
Well, you put yourself in his shoes. Where are my children?
Yes, I felt that he was very troubled and very sick. And I just wanted them around him.
Yes. Yes.
Who can know the need of their father any more than themselves? I mean, they fit in. He's content to sit and watch his grandchildren around him. Nothing would please him more. Sometimes they get too loud, but if they just come in once a month, you know, this takes him by surprise. But if they came in and dropped in, if they lived close and dropped in, this would be a very significant thing. There's some things there. It may be memory that you can find. It may be recognition. He's not absolutely gone.
No.
I hate these people that say vegetable. I'm telling you, it just sends me into a frenzy. What do they mean by that term? Vegetable. I've heard physicians use it. It's a non-person. When do you become a non-person? When does a vegetable ever become a person? You know, there's a lot of philosophy in this, and where's Harold's soul right now while all this is going on? You know, is he just in limbo whenever he's in these comas or whatever may happen to him?
This kind of problem calls on all the empathy, all the wisdom, and all the care that a doctor has to give to his patient. And sometimes it's not a word or a phrase, but a hug or a held hand or even a mutual tear that constitutes that day's psychotherapy. Family support groups, especially those associated with medical centers where there is someone interested in the dementing disorders, have been one of the major resources for the caregiver.
Talked to a couple of people in front of Helen, and she raised a row about it. She raised a row. She doesn't want nobody in the house.
But it isn't really her decision, it's your decision.
It'll have to be my
But Manny,
decision.
they get over
But then you have to make the decisions and then try to make them
But
work
she carries out
with the
so much
patient.
of them. She's now really going to need help now, because she's gotten to the point where she's practically unmanageable. I brought it up 2 or 3 times. She overheard me talking about it, and she became very, very...
But you've got to learn to overcome that. You know, the resentment, once she's familiar with the situation and the person, maybe that will change. You've got to try
She's
it.
even gone out and told people that I'm beating her up now.
Well, you know you're not, so you've got to overcome that
I was
too.
surprised. She went to a friend of mine and told him I was beating her up. I said, that's impossible. We know each other for over 25 years.
How did that make you feel?
It didn't make
It
me feel
hurts,
too
because
good.
there you are trying to help,
I'm
you
trying
know.
to get help for her, but it didn't do too much good.
My wife she has plateaued, and then she'd drop a little bit, and then plateau, and then drop a little bit over a period of many years. But in the last 6 months or so, it's been a little more precipitous. However, she has no ability to articulate her thoughts, and therefore we practically have no conversation. We go for hours on end without talking to one another.
Why don't you keep on talking just anyhow?
I've tried that.
Like talking to a wall.
Well, you don't get any response?
No, you can see a response in her eyes, but she can't come out with anything.
Yes, but that's
see.
good. I mean, don't stop. Just, you got something there, and tease it out. I think you have to tease it out of them.
Yes,
She's agitated.
it's
That's
there.
an emotion. You say that she...
It overpowers you.
Yeah.
And I'm so worn out that I just can't fix supper and clean up and all of that stuff by the end of the day, and I need help. So we got this lady to come in, and that was a part of it, and she became a companion.
But Manny, there's nothing wrong with that. You and your wife have been close for 46 years. And that can still stay. She just, what's hooked in here is now you are her only environment that she's familiar with. You are her total environment. So you have to bring in a little more new environment there, and just hang in there. When you said you get turned down, you find somebody that didn't want to come in. There's a lot of caring people out there. Don't give up.
When pressures increase on the caregiver, it may be necessary to advise them to begin to share their responsibility with a second caregiver, either another family member or someone specifically recruited and hired for that purpose.
And you shouldn't blow the chance when you got the chance to say, can't you go on?